So my talk today is coronary CTA, patient preparation and protocol selection. I know it says dealing with difficult patients, but I'd rather you not deal with difficult patients. If you know how to do the proper patient preparation and protocol selection. For this talk, I have no disclosures. And so I'd like to discuss common indications for CT angiography of the coronary arteries in the pediatric and adult settings, provide an overview of patient preparation and protocol selection for CTA of the coronary arteries. Common indications in the pediatric setting include evaluation of congenital coronary anomalies, right, such as anomalous origins, follow-up evaluation of Kawasaki disease, pre-surgical planning in patients with congenital heart disease, and evaluation of potential surgical complications. This is vastly different than in the adult population, where the single most primary indication for coronary angiography, CTA of the coronary arteries, is coronary artery disease, stable angina, right? And the next list for that is effectively pre-surgical planning for coronary artery bypass graft and post-surgical complications. So the vast majority of our patients in the pediatric setting are referred for cross-sectional imaging following echocardiography. Echocardiography can reliably identify the ostia, but it's user dependent, right? So it's entirely dependent on the technique used by the person performing the ultrasound. So it's not as consistent as CT. For this reason, oftentimes when only the coronary ostia are identified and there's potentially an abnormality, patients are always followed with CT. The next question, right, following how was your patient referred to you, is whether or not you use sedation or anesthesia for a pediatric patient. Modern CT scanners have improved temporal resolution, allowing free breathing for most scans. Children who are older than 6 to 7 years old can hold their breath and usually do not need sedation. Very young infants typically do not require sedation. If you use feed and swaddle techniques, and also give them a little bit of sugar on a pacifier so that they're at least satiated for the time being. Older infants are often image sedated but free breathing, and general anesthesia with suspended respiration is occasionally required for young children, particularly for the evaluation of the distal coronary arteries, right? So usually, if you have access to a power injector, EKG leads, right, and a scanner that's capable, you really don't need anesthesia to be on board in order to do cardiac imaging for the pediatric population. So considerations for your patients, depending on the scanners that are available to you, are detector thickness, right? So Siemens scanners, the Siemens Force has an 8 centimeter detector thickness. Philips GE Revolution has a 16 centimeter thickness, right? So depending on how small your patient is, you really don't need the table to move at all, depending on your detector thickness. If you use dual source technique, you can actually reduce, you can improve temporal resolution if you increase the rotation of the gantry. And separately for the pediatric population, we really don't have access to medication. We normally do not give children vasodilators, and we do not rate control the pediatric population with beta blockers. This means that you are going to be limited in the quality of your images because children oftentimes have a higher heart rate. And so this brings us to how are children different? So my colleague beforehand said that children are not, small adults, right? They have smaller organs and structures. The coronary arteries are only about 1 millimeter in diameter, right? In some instances. They're less likely to follow orders, right? I don't know if many of you have children, but my children don't listen to me. This is my son. And so they have a higher radiation sensitivity, so you have to be mindful about the techniques, the protocols that you select in imaging them. They have higher respiratory rates, right? So higher heart rates and higher respiratory rates results in cardiorespiratory motion artifact, which further degrades your image quality. And so this brings us to how do we appropriately image them? So historically, and still used today for functional analysis, we performed retrospective gating acquisitions, where in a step and shoot format, the heart was imaged across the cardiac cycle in sections, and the images were stitched together in post-processing. This technique used higher contrast volumes, right? Because you have to image the heart in sections, which means that your volume of contrast has to persist in the heart. You had more artifact, right? Because you're using a step and shoot model and you're reconstructing the images, which means that cardiac and respiratory motion artifacts are propagated and are actually magnified using this technique. But for all of its faults, retrospective gating is still the only way on CT imaging where we can actually do a functional analysis. So more commonly today, we employ prospective gating, where the time of phase of the cardiac cycle of the heart is most quiescent in the pediatric population given their high heart rate and systole. In adults, the heart is most still during diastole, so it changes when you image. For the pediatric population, you'll shoot for more of the 35% RR interval, whereas in the adult population, you're looking at 70% of the RR interval. So prospective gating also reduces radiation significantly, right? Because you're not doing a step and shoot model, you're predicting what the heart is going to do, right? Usually in the pediatric population, their heart is small enough, so the pitch, the table movement is not as significant. So oftentimes, depending on if you have a neonate and you're limiting your Z-axis coverage to the heart, you really don't need the table to move at all. But all of these exams use a power injector, and power injectors can be used safely with peripheral IVs as small as 24 gauge. Usually in children, the way that we administer contrast, we do weight-based dosing. So it's usually 1.5 to 2 milliliters per kilogram of contrast. We follow it with a saline flush. The main complication, just like in adults, is extravasation. Similar rates occur in children. But I'd like to draw your attention to the table below. You can see that depending on the age, we're really limited in how fast we can inject, right? And you actually don't need higher rates of injection for smaller patients because the flux. So there are a number of different things that determine the quality of your contrast opacification, right? The first is you have to use as low a kV as possible, right, to get close to the kH of iodine, which is 33, which means if you multiply that by 2, the best scenario is if you use 70 kVp for your scan, right? The second component to determine the quality of your contrast bolus is how much contrast are you using? So what is the flux? What's the concentration of iodine per volume of blood, right? So if you inject as fast as you can, depending on the limitations of your IV, and you use as low a kV as possible to improve the quality of your scan, then your contrast opacification will be perfect. And you can see here that oftentimes when you use a power injector, you have to set an upper limit for the PSI. So if the PSI for our patient exceeds 300, then oftentimes the power injector stops injecting, because above 300 PSI, you have a higher risk of contrast extravasation. And finally, for the technique, you have to place your region of interest for your bolus tracking for the structures that you want to image. So if you're looking at the coronary arteries, you can place your region of interest in the ascending aorta or the LV. So that brings us to the case that I wanted to show you, and we're doing really good on time, right? So we can probably try and see if this will work now. Is it possible to do Wi-Fi? To show you online, effectively showed you Kawasaki's disease. Here you can see this patient's chest x-ray, 10-year-old presenting with chest pain and exercise-induced ischemia. You can see there that there are these calcified structures in the mediastinum where, depending on your region of practice, you might think that they're calcified lymph nodes. But in fact, when you did the CTA, you realized that they're peripherally calcified coronary artery aneurysms. And so this is a patient who had untreated Kawasaki's when they were younger. And usually we see this level of disease in patients who are not treated during their episode, right? And so this brings us to our summary, right? So plan for sedation or anesthesia services if needed, noting most children can be imaged safely and with high quality, with free breathing and without sedation. Select the proper protocol for the clinical question. If they want functional analysis, you really have to do retrospective gating, but you can get by with prospective gating because in children, we're not really looking at coronary artery disease, right? So we're not looking at a stenosis. We're looking to see whether or not they have pathology like Kawasaki's, or you're looking for general anatomy for surgical planning. So you don't have to have a perfect exam. So vasodilation and rate control are not necessary. And finally, for all cardiac imagings at our institution, the radiologist has to be present at the scanner because you cannot ask a technologist to do this level of protocoling, right? That is not in their expertise. And so you being present at the scanner, looking at the parameters, changing your RR interval, reducing the KVP if you need it to improve your contrast bolus opacification. And finally, to review the images at the close of examination, Oftentimes children, it's very hard for them to come to the hospital. Their parents have to take time off of work. And so being able to be present for the image acquisition allows you to make sure that the image quality is sufficient for your diagnosis. That is how you avoid difficult patients. These are my references. Thank you for your attention. Sorry the website didn't work.